We will be presenting a case of a patient who underwent a bladder augment with a Studer Type Neobladder to treat severe urinary tract dysfunction associated with chronic ketamine use. This is a 27-year-old female with a past medical history significant for polysubstance use disorder with recent development of bilateral hydronephrosis without obstructing stones and with an associated AKI. This was managed with bilateral percutaneous nephrostomy tubes. The decision was made to pursue partial cystectomy with Studer Type Neobladder Augment and bilateral ureteral reimplantation. Cystoscopy was performed, revealing a highly trabeculated bladder, and urodynamic testing demonstrated a high-pressure bladder with a severely diminished capacity of approximately 50 milliliters. On antegrade nephrostogram, the patient was shown to have bilateral ureteral strictures at the left ureterovesical junction and right mid-ureter. Ketamine bladder syndrome is pathology seen in chronic ketamine users marked by severe urinary dysfunction such as low capacity, irritated voiding, and bothersome LUTs. In this case, we demonstrate the use of a Studer type neobladder as an augmentation cystoplasty. The neobladder is attached to the base of the bladder after partial cystectomy rather than a true neobladder, where the urethra would be attached after a total cystectomy. The patient was prepped and draped in a sterile fashion in the dorsolatherectomy position. Ports were placed in standard position for the robot-assisted laparoscopic pelvic procedure. The Verus needle was used to insufflate the abdomen to 15 millimeters mercury. A 12 millimeter left lateral port and an 8 millimeter left cephalid air seal assistant port was placed in standard position. The patient was placed in steep Trendelenburg and the robot was docked. The left ureter was dissected down to the ureterovesical junction, where the ureter was clipped and ligated. Attention was then turned to the right ureter, which was noted to have a transition point consistent with a stricture as it entered the pelvic inlet. The right ureter was then dissected down to the ureterovesical junction, clipped and ligated. The bladder was distended and capacity was estimated at roughly 80 milliliters. A partial cystectomy was performed with the dome of the bladder completely removed. The bowel was carefully examined to determine the most dependent portion of the terminal ileum near the ileocecal valve, marking it with a 3-0 V-lock suture at the junction point between the bowel and the mesentery. Separate marking sutures were placed at 11 centimeters and 22 centimeters proximal to this point. A space was created posterior to the sigmoid colon to transpose the left ureter to the right side. An additional 22 centimeters of bowel was measured proximal to the previous marking suture, and the bowel was detubularized proximally and distally for a total length of 44 centimeters. An additional 5 centimeters of bowel was harvested for use as an ileo-ureter, and another 5 centimeters of bowel was harvested as a discard segment. The harvested bowel intended for the neobladder was placed posteriorly, and a stapled side-to-side bowel-bowel anastomosis was performed in the standard fashion. The neobladder was rotated counterclockwise 90 degrees, and the most dependent and posterior portion was affixed to the cystectomy using 3-0 V-lock suture. A 3-0 V-lock suture was used in running fashion to perform anastomosis between the ilioneobladder and the bladder. The ureteroenteric anastomosis was performed with an end-to-side spatulated Bricker-type anastomoses with 4-0 vicryl suture in a running fashion. Both anastomoses were stented, 8 French by 30 cm on the left and 8 French by 28 cm on the right. A 24 French Foley catheter was inserted into the urethra. The neobladder was noted to distend, accommodate a much larger volume of saline, and was noted to be watertight. Total operative time was roughly 7 hours, with minimal blood loss. At 4 weeks post-op, patient underwent cystoscopy with bilateral stent removal showing resolution of hydronephrosis. The patient's bladder capacity is currently greater than 400 milliliters without leakage. In summary, we had a 27-year-old female who underwent a partial cystectomy with Studer Type Neobladder augmentation for severe ketamine-induced urinary dysfunction. Ketamine bladder syndrome can be debilitating, and complete cessation of ketamine use does not resolve symptoms for all patients. Surgical intervention may be effective in such cases.